Our next speaker is a another very versatile young individual from Raghudeep Eye Hospital from Ahmedabad, a leading cataract and refractive surgeon, Dr. SHAIL VASAVADA, who's going to dwell on another challenging topic, aberrometry and quality of vision assessment and its relevance in refractive surgery. And on to you. I'm sure you'll do a great job. On to you.
I think I've submitted the pre-recorded video, if that can be.
Oh, yes, yes, Sharik is,
sure.
Yes, yes. Could you play it, Mr. Sharik? Volume.
There is no audio in it.
No audio.
Sharik, you have to optimize your video now.
Yeah, for a change.
You tell everybody.
All of us do it.
Yeah, to optimize now you
Optimize
have to do that.
Typically flattening more is. Very good evening and many thanks to Dr. Chitra ma'am and the ARC team for this wonderful opportunity. I shall be talking about aberrometry and its role in quality of vision assessment. Affected in refractive surgery by the change in the corneal profile, mainly the asphericity and induction of higher order aberrations. The change in the keratometry, typically flattening more in myopic LASIK. The centration of the ablation that we do with respect to the visual axis, and of course OSD or dry eyes, which is the bugbear for any refractive surgery. Several studies have shown that just making a flap itself induces some or the other form of higher order aberrations. And it's been shown that amongst the different ways of making the flap, the femtosecond laser assisted flaps are shown to cause the least amount of higher order aberrations induction compared to a microkeratome flap. And that's one good reason more to consider femto flaps for all. As far as the normal cornea goes, the bending of the light that typically occurs from the periphery is relatively generally more, which leads to positive spherical aberrations. In a myopic LASIK, which is the most common form of refractive surgery, there is further flattening in the central cornea, which leads to an increased relative bending from the peripheral areas, which leads to more positively induced spherical aberrations that can affect the quality of vision, particularly during night time, what is quite often described vaguely as glare, but could be anything ranging from such halos to spreading of light that occurs or which is experienced by patients. Spherical aberrations also induce myopia in low light, what is typically defined as night myopia. And this is one possibility that should always be considered in patients who complain of fluctuating visions despite a perfectly healed cornea. This is the aberrometry auto-refraction to suggest the same. That in a normal pupil size, the acceptance is, or the refraction given is on the pluser side. The more the pupil ups, more myopia is induced, and this may be the reason why some of the patients complain of poor quality of night vision, particularly while driving. Again, a case of high myopia, -8 diopters, and notice as the pupil opens up, the aberrations on the cornea also get more and more exposed. So it's very important to counsel these patients, particularly when you are treating high refractive errors, that some amount of aberrations will be induced, which will be increased during the night time as the pupil opens up. And this is the simulated vision to show the same, that as the pupil opens up, the quality of vision drops significantly. And therefore, always look for the mesopic pupil size, particularly when treating high refractive errors. Fortunately, in our population, we rarely see mesopic pupil size beyond 5.5 millimeters. But this is a point to be kept in mind. Coming to the question of which is better, wavefront guided or wavefront optimized as far as the aberration profile induced is concerned. Of course, topography guided has been discussed extensively, but still the most commonly performed is the wavefront optimized or the aspheric profile, particularly for myopic refraction. And we did our own study of 72 eyes where all patients were subject to the eye trace in mesopic pupil condition as well as at dilated 6 mm pupils. And what we found was that at the 6 mm pupil size, there was a significant increase in the total higher order aberrations, coma, and the trefoil. However, when we looked at the mesopic pupil size, which was on an average about 4.8 millimeters, the difference that there was a trend towards increase in the post-operative aberrations of all kinds. However, this difference was not statistically significant. So as far as the mesopic pupil size of most of our population of patients go, it's not something to be very worried about. And therefore, wavefront optimized profile is, I would say, at par or as good as treatment of myopic refractive errors as far as aberration induction is concerned, compared to the wavefront guided as well. So slight, but some very little increase at the mesopic pupil size, more at 6 mm pupil, so maybe more relevant to the Western population. The shape of the cornea also determines the aberration profile. And if you notice here, the ablation has been a little bit more decentered, leading to more coma and more higher order aberration being exposed to this patient. This is getting lesser and lesser common because of the improved pupil tracking devices in the newer generation lasers, but still you will come across certain patients like this with decentered ablations and who keep complaining about poor quality of vision. And this is the abrometry of that same patient to show how much this decentered ablation is actually affecting the quality of vision. And many of these symptoms sometimes described by the patients are actually genuine if you work them up. And it's not just the psychological symptoms that the patients are suffering from. And this is how bad the quality of vision of that patient who is still reading 6.6 or 6.9 on the Snellen's chart will be, particularly in dim lights. A similar patient on preparing for the NEET entrance exam, complaining of ghost images following LASIK 2 years back. And the profile is showing some early changes, possibly of ectasia, but decentration in the ablation, which is leading to more corneal aberrations being exposed. And we counseled her need for follow-up to look for any form of progression of ectasia. But for the time being, we suggested rigid gas permeable contact lenses. And this is the same patient after fitting of the RGP, the corneal profile has improved tremendously, and therefore the aberrations have improved. And therefore the quality of vision is also improved. How flat is too flat? This is something that we all need to be very careful about, particularly in thicker corneas where we get very tempted to treat very high refractive error. So this is a patient of -11 sphere, 594, which is very uncommon, but you do come across such patients. And if you do a 90 to 100 micron flap 6 mm optical zone, you can treat this error on the cornea itself. But remember, it's not just the error that we are treating. And if the patient has a preoperative keratometry flat of about 43, 44, this patient is going to end up somewhere around 30 to 33 post-operatively. And any keratometry reading, flat reading less than 34 diopters compromises the quality of vision significantly. This is a large study of 8,500 eyes, where almost half of the eyes had less than 40 diopters keratometry. And flatter the keratometry, higher the prediction for halos. However, it was not a significant predictor for glare or starbursts or double vision. Therefore, ICL, which is more closer to the nodal point of the eye, may be more useful in high myopes. Even small flap striae like this can affect the quality of vision or the aberrations that the patient sees. This is the same patient of the previous photoslit image, showing the corneal aberrations which are affecting the quality of vision. And this is the point spread function of that same patient, not a great vision quality that the patient is seeing through those flap striae. Similarly, the same goes for epithelial ingrowth, particularly if they are coming close to the pupillary axis. This patient showing significant corneal aberrations due to the epithelial ingrowth and a very poor point spread function, leading to a very poor quality of vision that this patient is seeing. How do you treat these quality of vision issues? I think topo-guided ablation, as has been highlighted and is being talked about, is definitely a very good option. Rigid gas permeable contact lenses, the simple ones, or the rose K or semi-scleral or scleral contact lenses, which are available for keratoconus, work very well. But as all of us have learned, and we have learned from all our teachers and seniors, time is the biggest healer in most situations. So this was probably the largest study, the Prowl study, patient-related outcomes following laser in situ keratomelusis, which showed that less than 10% of patients have, significant bothersome symptoms, extremely bothersome symptoms post LASIK, and they reduce drastically over a period of time. Most of them would report somewhere. The most common initial symptom reported was double image, but glare, halos, and starbursts are these other most common symptoms reported. A small word about lenticular refractive surgery and visual quality. Here the causes are a little different. Residual refractive error is the most common cause of visual dissatisfaction in multifocal IOL patients. So treat the residual refractive error, and many of the symptoms quite often that we describe are not related to the rings of the IOL, but just uncorrected astigmatism, which is causing visual blur. So there will be some patients like this. We had one such patient that his unaided acuity is wonderful, N6. He says his vision is good, but it's not crisp, and he finds very difficult in reading economic times, where the contrast, it's made up of recycled paper. So there's yellow and black. The paper is yellow, the font is black. And he finds difficulty in reading it, and clarity improves when he uses extra illumination. So pre-warn or forewarn these patients that they will have some reduced contrast sensitivity, and they must be prepared to use higher contrast if you're using digital devices, or more light or extra light while reading. And just one final word, that it's ultimately where the IOL sits in relation to the visual axis and the pupillary axis of the patient. And if the difference between where the IOL sits, which is typically at the center of the limbus, in the center of the capsular bag, versus where the visual axis of the patient passes, if the difference is too large, the light is going to be passing through the rings of the IOL, and therefore the quality of vision is going to be affected. So any angle alpha more than 0.5, 0.6 is something also to be kept in mind. So aberrometry helps significantly in decoding, I would say, many of these unhappy patients, or patients who keep complaining of quality of vision issues where everything clinically looks apparent. And this learning helps us in pre-selection of such patients and pre-counseling of these patients, and probably also help in the coming times in designing more customized treatments for these unhappy patients in the coming times. Thank you very much for the patient listening.
Thanks a lot, Dr. Shail. So basically what we all understand is wavefront understanding aberrometry has more relevance in evaluating the post-op situations, or why the patient is unhappy. Would any of you, Dr. Merle is there, I don't know if she's connected. I've not asked her a single question because I think she joined late. Is there a cutoff of higher order aberration beyond which you would take a call that you're not going to do a LASIK for this eye, or you do a wavefront optimized, or you do a topo-guided, or you do a phakic IOL, or leave him with spectacles? Dr. Merle, are you there?
Yeah, I am there, but actually I have not been looking at the wavefront aberrations,
Yes.
in that detail. Previously, when
Yes.
we were doing wavefront guided treatments, then it used to be a point that we used to look at them, treat them accordingly. Anything that was more than 1 micron was a point for us to treat. With the MEL 80, we have the option of looking at point spread function and understanding how the treatment of specific aberrations would actually bring that point spread function back to normal. But subsequently, when we upgraded to MEL 90, we realized that nobody looks at those aberrations at all.
Yes.
And so I don't have a cutoff. I'm not sure if the others do, but I don't have a cutoff of aberrations that I need to treat. We, everybody was talking about contoura. We have, patients who have got higher cylinders in which we would like to do a contoura, but I don't have a cutoff for the aberrations per se. I think if patients have problems post-operatively, then you would look at the induced aberrations and see where they are. If there's a decentered ablation, I think Shail pointed out very nicely that decentered ablations tend to cause a lot of glare and halos. In those cases, you might want to do a treatment which would correct for that. And I think those options are possible.
Yes, 100%. I agree with you entirely. But Praveen, you have a question, or shall we jump to the next speaker? I think we started off with too many discussions, so we got stuck.
Yeah, I think we should go to the next speaker, because I think we still have 4 more. I think we should go on.